reintroduce my dear friend, Dr. Pieter Maré. He's from South Africa, and this is a second talk, and Peter's going to talk about managing bone defects in chronic hematogenous osteomyelitis. Thanks, Peter.
All right. So I'm going to be talking about the management of bone defects in chronic osteomyelitis. I've no disclosures for this talk. So children who present with chronic osteomyelitis often present with long-standing pain, malodorous chronic sinuses, which prevents them from attending school. They're ostracized in their communities. They may have exposed bone with soft tissue defects and loss of structural integrity. On top of that, deformities and leg length discrepancies coupled with joint stiffness compound their functional deficit. And it's unfortunate that the largest burden of this disease are in low and middle income countries, and these are often also the sites that are least equipped to manage its complex reconstruction. However, there is hope. If one has a structured approach to treatment, these infections can be eradicated in a large proportion of these cases. But there has to be a systematic approach. So one has to support the host system, treat iron deficiency, anemia, and worm infestations, treat malnutrition, optimize HIV treatment. The infection can only be eradicated by surgery. So it's incumbent on orthopedic surgeons to cure this. Soft tissues are crucial, both in terms of the selection of the reconstruction procedure, and it may soft tissue cover techniques may need to be followed during the treatment as well. Skeletal structural integrity should be maintained during healing or obtained in the case of segmental defects. And then deformity correction should be factored in as well as functional rehabilitation. Now, surgery for chronic osteomyelitis can be divided into two big groups. The first group is just simple infection eradication procedures for contained defects or conical defects with structural involucrum. One may need to support the skeleton with cast immobilization or external fixation during this process, and soft tissue reconstruction. Local flaps may be required. The second group is segmental bone defects, and these are more complex reconstructions, and often deformity correction needs to be achieved at the same time. So the timing of surgery is critical. One doesn't want to create unnecessary segmental defects. So once acute hematogenous osteomyelitis has declared itself as becoming chronic, you don't want to rush in and do a sequestrectomy of too large a segment. Some research I'm showing here shows that you have to wait at least 3 months after the appearance of the sequestrum to see whether the involucrum will form and spread a defect, and you will often be surprised in young kids how effective that can be. But so shouldn't be waiting longer than 6 months. So probably the ideal period is between 3 and 6 months before sequestrectomy. The role of antibiotics are merely adjuvants. They cannot penetrate devitalized tissue. We routinely use them preoperatively for infection suppression while waiting for the involucrum to form, and postoperatively empiric and directed for 6 weeks in total. However, satisfactory results have been obtained where antibiotics were unavailable or only used selectively. Reconstruction options are either conventional cancellous or corticocancellous bone graft or non-vascularized fibula, or the salvage fibula transfers, which we've seen some cases of already in previous sessions, and then the complex reconstructions, vascularized fibula graft and bone transport. Before I go into some case discussions, I just want to stop for a moment here at the Masquelet technique, and this has really been a game changer for us. It's a staged debridement and reconstruction technique using, after sequestrectomy and debridement, inserting antibiotic-eluting PMMA spacer with heat-stable antibiotics. We typically use gentamicin, and this creates a biological chamber with a well-vascularized induced membrane that promotes vascularization and bone formation of your bone graft, and it prevents graft resorption. So conventional techniques, this was done just down the road from us in Durban. These authors showed good results with a segmental bicortical iliac crest graft for defects up to 8 centimeters. And you can see that it looks like a kebab there, iliac crest squared and threaded through with a K-wire. This, however, is only when there's a good vascular bed and at least a partially intact periosteal sleeve. The advantages of a non-vascularized fibula graft is that it's simple, structural, and available. However, reactivation of infection may happen. Non-union is always a problem, and slow incorporation of the graft with fracture. So this is a case, just to demonstrate, this is a 3-year-old who presented to us with acute hematogenous osteomyelitis. He presented late, unfortunately, and this is at 6 weeks. You can see it's becoming chronic. This is a 3 months well-developed sequestrum with proximal and distal fracture. There you can see the cement spacer after our first, it's a few weeks after our first stage. We use the external cast immobilization during this period. Just a technical point, you can see the cement spacer is obliquely placed there, and that's not on purpose. You should avoid that, because you can see our non-vascularized fibula graft is now sitting in the same oblique orientation, which is obviously not ideal. It did go on to unite, but soon after removing the fixator, it fractured. Fortunately, we managed to get him to unite with a patella tendon bearing cast with a walking rubber. So not an easy course of treatment, but successful in the end. The next procedure is the fibula transfer. Many different variations of this technique has been described, both in terms of surgical approach, staging it, proximal and distal transport, or synostosis without transposition. It's relatively simple only when compared to bone transport, and it is still a salvage procedure because it still has a high complication rate with non-union, infection, reactivation, fracture, and deformity that can occur. Vascularized fibula grafts, of course, it's got an advantage that it brings its own blood supply. It doesn't need to incorporate by creeping substitution. However, it's extremely complex. There's still a high rate of vessel thrombosis. In our institution, the biggest problem is access to theatre, and the time it takes is just really prohibitive, besides the fact that the expertise required. Donor site mobility should always be considered as well, so late ankle valgus on the donor site is a concern. The Ilizarov technique we're much more enthusiastic about. It allows radical debridement. During bone transport, it increases the blood supply to the limb 3 to 10-fold, which helps with infection control. It allows early functional weight bearing and joint range, and simultaneous correction of angular deformity, leg length discrepancies, and one can achieve compression at the docking site. It is, however, a complex technique, and close surgeon oversight is required to make sure that the rate and rhythm of distraction during bone transport is within the safe range. Pin site problems are ubiquitous. All of these kids end up with pin site problems, but they're generally manageable. Very small percentage of them need pin revision or return to the OR. It's specifically challenging in small children, and with large transport, joint subluxation or stiffness can occur. Delayed consolidation and non-union at the docking site are, in a small percentage of cases, are a concern. So this is the next case. This is a 13-year-old girl who presented to us after the management of acute hematogenous osteomyelitis at another site. By the time she came to us, she had a very malodorous draining sinus with gram-negative co-infection. So he performed a first stage resection of necrotic material, cement spacer, monolateral external fixator, and a bilateral bipedical flap to achieve soft tissue cover. We then inserted a non-vascularized fibula, which is a large defect, so you can anticipate problems already. See a distal non-union there, which we deemed to be hypertrophic with low infection markers. So we increased the stability of the construct. Initially, it looked like it was uniting, but then she presented back to us with infection reactivation and proximal fracture. So we're back to square one. And what we decided to do then is this procedure, which is bone transport through an induced membrane. This was written up by some of our adult reconstruction colleagues. And this is basically what we've done for her. So on the left, you can see the cement spacer, middle slide, the defect after removal, and a transport frame. And on the right, it's a bifocal transport, proximal to distal, distal to proximal. This is after union. And this is a clinical image. So you can see her structural integrity has been restored. The infection is quiescent, and she's restored to function. So take-home messages: prevention is better than cure. We need to pick up these acute hematogenous osteomyelitis children early and manage them appropriately, avoiding any anteromedial tibial incisions so that we don't end up with soft tissue problems late. If they do go on to chronic osteomyelitis. Once chronic osteomyelitis is established, an adequate debridement is essential if there's any chance of getting cure. Once the structural defects exist, they are very complex to reconstruct, but there are many different reconstruction options available. Know the advantages and disadvantages, expect complications, counsel the patients appropriately, and there is hope of cure if one follows a structured approach. Thank you.